It's the 27th of May, 2016, and this is the RheumNow Week in Review. Hi, I'm Cush, Executive Editor of RheumNow.com, and this week in the news, we have several interesting items. A large cohort report gave some surprising information about salt and diet. You know, I've written about salt and the importance of low-salt diets and sort of avoiding autoimmune phenomenon, but in the real world, salt equates with higher blood pressure, higher cardiovascular risk, but the data in favor of that is actually sort of scant. A very, very large cohort study showed that in hundreds of thousands of patients, the low-salt diet was actually associated with more heart attacks, more CVAs, and more cardiovascular deaths. It appears that the patients who benefit most from a low-salt diet are those who are on a high-salt diet, who actually have a hypertension and other cardiovascular risk factors. So it does play a role, but in cardiovascular health in general, avoidance of salt may not be as protective as we had previously hoped. Last week in the FDA, there were new rule changes about labeling and food labels, and that there would be greater emphasis on food labels and greater detail, especially with regard to sugars. This is a new mandate, however, it's going to take a few years to take effect. Several reports have appeared in the literature recently about late onset neutropenia in association with Rituxan use. This is not a common phenomenon. In several studies, it's been shown to be around 6.5%. And is not usually associated with increased risk of serious infections. Interestingly, treatment with growth factors like GCSF did not necessarily correct the problem, but nonetheless is something that should be looked for over time in patients who are on chronic therapy. A report shows that looking at large claims data and RA patients undergoing major surgery, that there was not an increased risk of post-operative cardiovascular events, complications, thromboembolic events, or mortality, and that's for RA patients undergoing major surgery. A cohort study of patients with polymyositis and dermatomyositis showed that 17.2% of patients with those disorders may develop cancer. You know about the risk of cancer with largely dermatomyositis. This study reaffirmed that it was predominantly dermatomyositis and not polymyositis, 23% versus 9%, and that the risks seem to be higher in those who are older, not surprising, those who manifest a heliotrope rash, Gottron's lesions, dysphagia, and low CPK at presentation. I think you should take a look at one of our blogs this week, written by Dr. Kelly Crone, who's done a book review of the book entitled When Breath Becomes Air. It's written by a physician and his travails in medical school, becoming a resident, becoming a neurosurgery resident, becoming a faculty member and a researcher, talking about medicine and life, and then talking about his own medical illness, which led to his death, which happened before the end of the book. Excuse me. Excuse me. Lastly, in our tweets, we discussed the management of RA flares. And I gave some guidance in there that I think is worth considering. Number one, not all RA flares are treated with steroids. I think it's important to know the cause of the flare because flares usually happen for a good reason. Number two, optimizing therapy and ensuring compliance needs to be done. Number three, you need to rule out other non-RA causes of flares, such as fibromyalgia, poor sleep, a concurrent infection. Maybe your best options in managing a flare is immobilization and sometimes injection, local rather than systemic. And then lastly, non-steroidals, analgesic drugs, steroids, again, intra-articular preferred over intramuscular, preferred over oral. And why not other options in managing flares? I think we need to think outside the box because flares can be quite damaging. Patients who have lots of flares, in the end, in fact, do poorly. That's data from the BEST study. This week we had a number of interesting blogs and news items. I wrote a blog about listening to the patients, a story of a patient who told me about her family history and events in her life that had nothing to do with her arthritis, but were nonetheless very telltale, and says a lot about the interface between technology and real medical care, and sometimes one suffers if you're doing a good job at the other. In the news, we saw some interesting reports. The Orbit study, which was a pretty interesting open label trial of first-time biologic therapy with a TNF inhibitor or rituximab. This was done by Ian McGuinness and colleagues, and it gave some fairly interesting results, and in the end showed that rituximab proved to be equivalent to TNF inhibitor, and they used adalimumab or etanercept in that trial when it came to the initial choice of therapy, sort of dispelling the myth that TNF inhibitors first. As you know, Janet Pope wrote about that, and maybe that we should kick the TNF habit because there is good evidence for alternative therapies, either as a first choice or as a subsequent choice. The opioid prescriptions, as you know, has been in the news, an epidemic problem in our society. However, recent reports show that since 2012, the amount of opiate prescriptions actually has begun to decline, although there has not been a commensurate decrease in opioid-related deaths. Another report that was posted by Olga Petrina on our website talked about an interesting open-label trial proving again the efficacy of tocilizumab in patients with polymyalgia rheumatica. This seems to be where we're headed, maybe as a novel way of treating this problematic disease of the elderly, which has been largely a steroid-dependent management problem, if you will. And last week, we reported on the findings reported this week at the GI meetings, the DDW meetings, with a new anti-IL-23 drug, and that's risankizumab. A randomized placebo-controlled trial showed that either dose of this anti-IL-23 drug was superior to placebo in all measures that were employed in that study, including the CDAI, which is a traditional Crohn's disease measure. Side effects were favorable, nothing worrisome, but again, this is a novel way of approaching not only inflammatory bowel disease, but we'll be seeing trials of IL-23 inhibitors in patients with psoriasis, psoriatic arthritis, and ankylosing in the months and years to come. Yet another modality that will benefit our patients. That's it for this week. Go to the website if you want to look at these citations and read further. We'll look out for good news for you for next week. Hope you have a good holiday weekend. Happy Memorial Day.